In this segment, we're going to talk about sodium, the disorders of sodium, and the effects of hyponatremia and hypernatremia. So let me again use my whiteboard, and let's first talk about the physiology of sodium. And whenever we talk about sodium, we have always to talk about water with it, because wherever sodium goes, it creates hypertonicity. So water is going to follow to that compartment because water dilutes. So there are two major hormones that are involved in the sodium-water balance. Two major hormones regulate the sodium-water balance. And the first hormone is aldosterone. Aldosterone. And the second hormone is the antidiuretic hormone, or ADH. These are the two major hormones that regulate the sodium-water balance: aldosterone, and ADH. And if you notice, I intentionally made the S in aldosterone very big and red, because aldosterone is the major sodium fan in the body. Aldosterone, the mission of aldosterone is save sodium. The mission statement of aldosterone is save sodium, P potassium. That's the mission statement of aldosterone. Save sodium, P potassium. Retain sodium in the body, get rid of potassium. Keep sodium, get rid of potassium. That's aldosterone. Save sodium, P potassium. Whereas ADH is all about water. It's save water. Save water. Don't pee water. Keep water inside. ADH is about free water. So when aldosterone saves sodium, when aldosterone retains sodium, what is going to happen to water? Wherever sodium goes, water follows. So when aldosterone gives the order to the kidney tubules, don't get rid of sodium, reabsorb it, take sodium back to the blood, what is going to happen to water? It's going to follow sodium back to the blood. So aldosterone eventually leads to salt and water retention. Salt and water retention. Whereas ADH leads to what? ADH leads to water retention only. Water retention only. So aldosterone, salt and water retention. ADH, water retention only. Aldosterone, salt and water retention. ADH, water retention only. So let's keep talking about each one of them and the role of each one of them. Aldosterone. This hormone comes from the adrenal cortex. It comes from the adrenal cortex, the outermost layer. What's the stimulus that results or that stimulates the adrenal cortex to release aldosterone? What stimulates the adrenal cortex to release aldosterone? It is the activation of the RAS, the renin-angiotensin-aldosterone system, or the renin-angiotensin-aldosterone axis, the RAS. And again, what triggers RAS? What stimulates the release of renin and the release of angiotensin and then the release of aldosterone? It is hypotension, hypovolemia. Any condition of hypotension or hypovolemia The most sensitive organ in the body for hypotension and hypovolemia, the organ that freaks out with any slightest degree of hypotension or hypovolemia, is the kidney. And there are very sensitive cells in the glomerulus of the kidney, and these sensitive cells are known as the juxtaglomerular apparatus. Juxtaglomerular apparatus. They are cells like pressure sensors. Pressure sensors in the afferent arteriole, very close to the glomerulus of the kidney, and they sense any slight degree of hypotension or hypovolemia. And once they sense that, they immediately release renin. Once there is hypotension or hypovolemia, the juxtaglomerular apparatus releases tons of renin, and this renin will result in the formation of angiotensinogen, and then angiotensin 1, and then angiotensin 2. And angiotensin 2 will stimulate the adrenal cortex to release aldosterone. And what's the function of aldosterone? Salt and water retention. Salt and water retention. So when you retain salt, when you retain sodium, and sodium is volume, what's going to happen to your hypovolemia? Your hypovolemia is going to be corrected. What's going to happen to your hypotension? Your hypotension is going to be corrected because you added sodium and water follows. So this is going to augment the extracellular fluid and the blood volume. So that's aldosterone, salt and water retention. ADH, so aldosterone is secreted by the adrenal cortex, and aldosterone works on the kidney tubules. What is the order that aldosterone gives to the kidney tubules? Save sodium, P potassium. Reabsorb sodium, excrete potassium. Take sodium back to the blood, send potassium to the toilet. Save sodium, P potassium. And aldosterone also has a third function that I'm going to talk about in the acid-base lecture. ADH. ADH comes out from the posterior pituitary gland, and you can consider the posterior pituitary part of the hypothalamus of the brain. What stimulates the posterior pituitary or the hypothalamus to produce ADH? When your extracellular fluid becomes hypertonic, when your extracellular fluid is too concentrated, when it is hypertonic, when you are hyperosmolar, when your extracellular fluid is hyperosmolar, you're lost in a desert and you ran out of water. So now you sweat, you pee, and you're losing water, and your internal environment, your extracellular fluid is more and more concentrated. This is the trigger for your hypothalamus and for the posterior pituitary to release anti-diuretic hormone. And anti-diuretic hormone also works on the kidney tubules, and it's going to give an order to the kidney tubule: save water, reabsorb water, take water back to the blood, in order to dilute this hypertonic, hyperosmolar extracellular fluid. Take water back to the blood, take water back. So ADH has nothing to do with sodium. ADH has nothing to do with your volume. By the way, what's the easiest clinical way to check the blood volume? What's the easiest clinical trick to check blood volume? It is neck veins. It is neck veins. Okay? So if the neck veins are distended, you have hypervolemia. If your neck veins are collapsed, you have hypovolemia. If your neck veins are normal, you have isovolemia or normal volemia. So these are the two hormones that regulate the sodium and water balance. ADH, water retention only. Aldosterone, salt and water retention. Okay. Now let me talk about sodium. Sodium is the major solute of the extracellular fluid. Sodium is responsible for the tonicity of the extracellular fluid, as we explained before in the equation. The normal level of sodium is 135 to 145. Let's keep it simple. Let's agree on 140 as your normal sodium. 140 milliequivalent per deciliter. 140 is your normal sodium. If you have less than that, low sodium in my blood, sodium in Latin is also called natrium. So if you have less natrium in your emia, you have hyponatremia. So hyponatremia is sodium less than 135. By the same token, if you have high sodium in your blood, high natr in your emia, you have hypernatremia. Hypernatremia whenever your sodium is more than 145. And you know what? Clinically, the symptoms, whether you have hyponatremia or hypernatremia, you're gonna have the same symptoms. You're gonna have the same symptoms. Whether your sodium is too low or your sodium is too high, you are gonna have neurologic symptoms. You're gonna have neurologic manifestations. The simplest will be headache, dizziness, slight numbness around your mouth, headache, dizziness, numbness, and the worst is seizures, coma, death. Seizures, coma, death. So when you have mild hypo or hyper versus severe hyponatremia or severe hypernatremia, what determines mild or severe? Do we look at the blood result or we look at the patient's symptoms to say you have mild hypo or mild hyper? Do we look at numbers or we look at the patient to determine mild hyponatremia, mild hypernatremia versus severe sodium disturbances? You have to look at the patient's symptoms. And the patient's symptoms, if they are just headache, dizziness, numbness, that's mild hypo or hypernatremia. If the patient's symptoms are seizures, coma, death, that is not a symptom. What do you complain of? I complain of death. That is not a symptom. If you have severe manifestations, that's severe hypo or severe hyper. Because if you look at the numbers can be deceiving. Let me give you this example. Normal sodium is 140. If someone, let's say you have two patients, both of them have sodium 120. But one patient dropped from 140 to 120 in 10 minutes. And the other patient dropped from 140 to 120 in 10 years. Which one will have severe symptoms, do you think? The one who dropped from 140 to 120 in 10 minutes, or the one that took 10 years to develop this significant hyponatremia? Which one will have more severe symptoms? The one that dropped rapidly. So this is going to be severe hypernatremia. Hyponatremia. Severe hyponatremia. And this one is going to be mild hyponatremia. How can you say it's mild? The sodium is too low. It's 120. Yes, but it took you 10 years to reach that low level. So the symptoms are not very severe. The symptoms are actually very mild, as seen in congestive heart failure. Whereas if you give one patient 3-4 liters of D5W, the patient is going to develop severe hyponatremia in 10 minutes or whatever, because this will result in significant symptoms, and this patient can develop seizures. Actually, this patient can develop seizures. By the same token, if someone moves from 140 to 160 only in 5 minutes, this is going to be severe hypernatremia. If someone moves from 140 to 160 in 5 years, this will result in mild hypernatremia, because it's not about the numbers, it's about the symptoms, and what determines the symptoms is the rate of change in sodium. If sodium changes very rapidly, this is going to result in severe symptoms. If sodium changes gradually, this is going to, or slowly, this is going to result in mild symptoms. And all the symptoms of sodium disorders are neurologic symptoms, are nervous system symptoms. That's what happens when you have hyponatremia or hypernatremia. Back to this magic equation. Tonicity is twice sodium plus glucose divided by 18. Tonicity is 2 times 140 plus 90 divided by 18. Tonicity is 280 coming from sodium plus 5 coming from glucose. Sodium is the major contributor of tonicity. So I can say tonicity is sodium. So if sodium goes up, tonicity goes up. If sodium goes down, tonicity goes down. Correct? So we can say that all hypernatremias are hypertonic. All hypernatremias are hypertonic. That's 100% true. And I can say all hyponatremias are hypotonic. And that's 95% true. Why? Remember the equation? Tonicity equals 2 times sodium plus glucose divided by 18. So if you have normal sodium, 2 times 140, but instead of the normal glucose of 90, you have someone with severe DKA or someone with HHS, the hyperglycemic crises of diabetes, where the blood sugar is really very high, and instead of 90, it is 900. Now, 900 divided by 18 is 50, and this 200, this 2 times 140 is 280. So now the tonicity is what? Is 330. Now it is hypertonic. So in DKA and HHS, DKA and HHS, these are hypertonic conditions. These are hypertonic conditions. In hypertonic conditions, when the extracellular fluid is hyper, and actually the extracellular fluid is hyper because it has a lot of what? Glucose, a lot of glucose. So the extracellular fluid is hypertonic. And the intracellular fluid is what? The intracellular is always isotonic. So water is going to move out to dilute the extracellular fluid. Now, when water goes out, what is going to happen to the sodium concentration in the extracellular fluid? The concentration is always what? The concentration is always mass divided by volume. So the mass of sodium does not change here. So there is the same amount of sodium in the extracellular fluid, but what is increased is water volume, because you have the original extracellular fluid water, added to it the water that left the cells to dilute the extracellular fluid. So at the end of the day, the sodium concentration in the extracellular fluid will go down. So in DKA and HHS, you get hyponatremia in a hypertonic extracellular fluid. It is hypertonic because of the presence of too much glucose. It is hyponatremia because this hypertonic extracellular fluid drags water out of the cells, and the water coming out of the cells, it will dilute the sodium that is already present in the extracellular fluid. So the rule is all hypernatremias are hypertonic, all hyponatremias are hypotonic, except DKA and HHS, where you get hyponatremia in a hypertonic scenario. So all hypernatremias are hypertonic. All hyponatremias are hypotonic. Again, all hypernatremias are hypertonic. All hyponatremias are hypotonic, except DKA and HHS, where you get hyponatremia in a hypertonic scenario. Okay, let me review some important rules before I conclude this discussion of hyponatremias and hypernatremias. Sodium is volume, and neck veins are the easiest clinical way to assess volume status. Sodium is volume. If you gain sodium, you gain volume, and your neck veins will distend. If you lose sodium, you lose volume, and your neck veins will collapse. If you don't gain sodium or you don't lose sodium, nothing will happen to your volume, and nothing will happen to your neck veins. If you gain water, what's going to happen to your neck veins? Nothing. If you lose water, what's going to happen to your neck veins? Nothing, because water is not volume. Sodium is volume. If you gain sodium, you gain volume. If you lose sodium, you lose volume. And that's why we can divide hyponatremias and hypernatremias based on your neck veins. Actually, we use 3 names to describe your sodium condition, to describe your natremia. And these 3 names are first name, middle name, and last name. What's the most important name? What's the official name of any person? It is the last name. So the last name is the most important one. So we look at your blood test. Sodium is less than 135. That's hyponatremia. Or sodium is more than 145. That's hypernatremia. So the last name is your natremia. Is your natremia. Your sodium concentration in the blood. Your sodium concentration in the blood. Last name is the natremia. The middle name is the tonicity. And the middle name is the least important. And it goes without saying. All hypernatremias are hypertonic. All hyponatremias are hypotonic. And we talked about the only exception, DKA and HHS. So the middle name will be, for hyponatremia, it's going to be hypotonic. For hypernatremias, it's going to be hypertonic. And then the first name is volemia. You look at the neck veins. You look at the neck veins. If the neck veins are distended, that's hypervolemia. If the neck veins are collapsed, that's hypovolemia. If the neck veins are normal, that's isovolemia. So 3 names to describe your sodium condition. 3 names to describe your natremia. Is it? The first name is volemia. You look at the neck veins. The second name is the tonicity, hyponatremic or hypotonic or hypertonic. The last name is, are we dealing with hyponatremia or hypernatremia? And we are going to talk about these conditions in the next segment.